Very good afternoon to all of you. Uh, I would like to thank Roche and AIOS for giving me this opportunity to present. So I think it's very good now that we have a discussion on so many anti-VEGFs and we have so many tools in our kit that we can handle different diseases with the different anti-VEGF. So I'll be discussing that now we have to look the time to look beyond anti-VEGF agents, and this is my disclaimer. So the new molecule that is faricimab, which came in around February 2024, it has got a dual inhibition of the Ang2 as well as of the VEGF-A. So how does this help? First of all, theoretically, and then I'll just show some cases in my practice that how I'm using it. So this is basically the molecule. It is a bispecific molecule which has got two antibody binding sites, and one of them is against the VEGF and the other arm is against the Ang2. So this is the first bispecific antibody which has been used for the eye and is designed for the eye. So this is made by a technology that is known as a cross-map technology. That is a molecule which has got two antigen binding sites, which is a patent for Roche, and they basically use it. So there are two fragments in an antibody, the FC fragment and the variable fragment, that is the Fab fragment. And there is a heavy chain and a light chain. So they just use this technology to create this bispecific molecule, which I just stated as against the Ang2 and the is an anti-VEGF. So what is this role? So again a bit of theory. What is the role of angiopoietin in maintaining the homeostasis of the retinal vessels? How does it maintain the integrity of the retinal vessels? So this is basically the angiopoietin pathway. We have got the Ang1, which is considered as the good, you can say that is the good Ang. It binds to the Tie2 receptors, that is the tyrosine kinase receptor, and both of them, they help to maintain the integrity of the vessels. They help to promote good endothelial tight junctions. They help the pericytes to remain, they prevent the fallout of the vessels, and they prevent neovascularization and maintain the integrity of the vessels. But however, the other part is the Ang2, which you can say is like the bad one or the villain, which is the one if it increases in diseases like diabetic macular edema, RVO and AMD, and that will compete with Ang1 for binding to the Tie2 receptors. And what will that happen? That will lead to increased endothelial loss of pericytes, increasing vascular permeability, increasing inflammation. So the main thing here is with this salt, we are not only targeting the VEGF that leads to neovascularization, but also controlling the component of inflammation and fibrosis, which I'll also discuss further. So this is a study which was done in the mouse model, and they said that you can see the presence of leukocytes when they induced a uveitis in the mouse model. Leukocytes were seen within the retina, and when we treated it with anti-VEGF-A or anti-Ang2, then still some leukocytes were present. But when we treated it with a combination of anti-VEGF and Ang2, then there was a very significant difference in the absence of leukocytes within the retina. Hence it has got a definitive role in controlling of the inflammation, that is the inhibition of the Ang2. So as I said, it causes sustained inhibition of both Ang2 and VEGF-A. It leads to much more vascular stabilization, reducing the leakage and inflammation, and it also has an anti-VEGF action that prevents neovascularization. All these things combined lead to a longer duration of action, which we have witnessed that with a slower but a longer duration of action up to around 16 weeks in about 70% of the patients in the phase 3 clinical trials. So as we all know now, most of the retinal diseases are multifactorial diseases. They need repeated frequent injections. So our main aim is to increase the treatment duration and reduce the patient load, and also tackle the multifactorial part of the diseases. So as we can see that both VEGF levels as well as Ang2 levels are increased in AMD patients, RVO, diabetic retinopathy, and as well as diabetic retinopathy with PDR patients. So we have to, with this molecule, we not only target the VEGF levels but also the Ang2 levels. So faricimab causes rapid and sustained intraocular suppression of Ang2 and VEGF-A up to 16 weeks in the phase 3 trials in both neovascular AMD as well as DME patients. So you can see that first there is a rapid fall in the Ang2 and the VEGF levels, which gradually continue to increase and the peak again it reaches to the previous level at around 16 weeks. So the action is much more slower and sustained, and hence it needs a loading dose followed by a treat and extend protocol. So this is the suppression of faricimab, showing the suppression of ANG2 in comparison to aflibercept in the phase 3 clinical trials. So you can see that in 4 and 8 weeks there is almost a negligible amount of ANG2 which is present, which is below the quantifiable levels. However, with aflibercept, if you see that at 4 and 6 levels with aflibercept alone, the ANG2 levels tend to increase after 4 to 8 weeks with treatment with aflibercept. So what is the potential benefit of this dual inhibition is? It leads to vascular stability, as I said. It reduces the inflammation. This has been shown in phase 3 trials in both DME and AMD. I'll just summarize those trials. And this leads to much more possibility of increasing the duration of the treatment and decreasing the number of injections, as well as the decreasing the overall treatment burden on the patient. So these are the clinical trials. First for neovascular AMD, I think we have been discussed by the previous speakers also about all the anti-VEGF, the Tenaya and Lucerne, in which they showed a response that was equivalent to or not inferior to aflibercept, and then it has been extended. The only benefit is that the number of injections which were needed were less as compared to aflibercept with faricimab. Similarly, in DME, the AIOCMT and the Rhine study was done, and they followed a treat and expand or a PLI regime in which they gave first monthly injections, and then after 6 injections then they increase the duration. So this has also shown response that are almost equivalent to aflibercept. However, the number of injections which are needed were quite less. So these are the trials which are showing a good effect of faricimab. Now I'll just discuss few cases and how did I start using it. So this was one of my first patients. So this is a patient, he is a doctor himself. He received ranibizumab for a treatment. He comes from far, but there was no response, so we shifted to aflibercept. And his vision improved to 6/9. But the problem is that his vision kept on ranging from 6/9 to 6/18. After every 6 to 8 weeks, there was a recurrence of this subretinal fluid. So after receiving multiple aflibercept in December 2023, when he presented to me, I gave him an aflibercept injection because there was this fluid. In January, there was some amount of fluid which was still present, and the vision was also 6/9 parts. And at this time, at the end, the faricimab had came. We were waiting for that drug. And I gave him a Vabysmo injection, and after a single injection, there was complete drying, which was expected, which was also there with aflibercept, but there was a recurrence at 6 weeks. So I did a OCT at 6 weeks, so there was still no fluid. But since this is a switch patient, I did not give a loading dose. I gave him a second dose at 6 weeks, and after giving him 2 doses, this is the OCT at 14 weeks. And the patient is doing absolutely fine. He's on a treat and extend regime. He has gone up to 12 weeks. The vision has improved to 6/6. So what I observed in this, not only there is complete drying, but also the advantage is that it probably has a role in improving the outer layers of the retina. Probably because of the ANG2 effect, there is a decreased incidence of scarring which is present in some of these patients. So this is another patient who was on treatment on aflibercept. His right eye, aflibercept was given, treat and extend, and is absolutely fine, is doing great, does not need any further injection till date. However, the same problem in the other eye. After every 6 weeks, there is this recurrence of this subretinal fluid, these small PEDs, the SHREM is there, the PD height increases, and the vision deteriorates by 2 to 3 lines. So again, in this patient, in January, I gave him an injection in February. He presented in January, there was complete drying. But after 2 weeks again, he presented in the first week of February. There was this recurrence of this fluid. Again, you can see that the PD height has started to increase, and this is the time I gave him a faricimab injection. And following 6 weeks again since this is a switch patient and the patient was doing fine up till 8 weeks, I decided to give him a faricimab at 6 weeks. So this is at 12 weeks, this patient was absolutely dry. I decided to go for, rather than a treat and extend, on the PRN regime because this patient has received several injections. Although he needed an injection at 16 weeks, he is getting injections at 16 weeks. And I am shifting something between a PRN and treat and extend. But again, this is the second case which was getting a recurrent fluid with aflibercept, but however with Vabysmo, the duration of dryness has increased by about 8 weeks. So this is a treatment naive patient. So this patient is an old patient. He earlier had CSC and there was no problem. The CSC had gone away, but one day he presented with this vascular membrane, which was also seen on an octa. I don't have the images. There is a PD, there is a double layer splitting sign on the OCT, and there is presence of subretinal fluid with a well-defined AVN which was present. And after a single injection of aflibercept or faricimab, there was complete drying, which is also observed with other anti-VEGF agents. But the good thing is that the PD height also reduced. In this patient, I decided to follow the normal protocol of giving a loading dose. So this is following the first loading dose and the second loading dose. And 1 month after the third loading dose, the patient is doing absolutely fine and has a dry macula. So this is another case. This is a chronic case. So he's a one-eyed patient. There was some scarring, some retinal fluid. So I offered him Vabysmo. The patient was very keen for treatment, although such cases do not improve. But there was some intraretinal fluid there, some retinal thickening. After single injection, what you can observe is there is an improvement in the contour, and also the scarring amount has gone down. The neovascular complex has reduced in size. So this is following 8 weeks, and this is the last. As I said, the outer retinal contour tends to improve. There was an improvement from 3/60 to around 6/36, and the patient is extremely happy with the treatment. Just 2-3 slides more. So this is a case of DME. So the patient has received multiple aflibercept, left eye also Orzodex, and this I just wanted to state, this is a very non-compliant patient. The moment he gets better, he stops coming. So I decided to give a faricimab, and after a single injection of faricimab, there was a significant reduction in the cystic spaces, although not completely gone. Unfortunately, this patient is very irregular, has not come for further treatment, but whenever he comes, I'll come to know how the future response was. But after 4 weeks, there was a very good response by treatment with faricimab. Another DME patient, single injection faricimab, complete drying and a marked improvement in the contour of the retina. So this patient has not required any further treatment and has a good control of his systemic status, and with one single injection went fine. This is my last case, so just wanted to highlight few I've used in many cases. So RVO, although it is not approved in India, but I gave faricimab looking at it. So there is some CME, this is a HRVO case. So after single injection of faricimab, there is complete drying, which I think will also be achieved by other anti-VEGF agents. But the best part about what I observed is that there was almost complete disappearances of this hemorrhages after 3 weeks after the injection, which is not usually observed clinically with other anti-VEGF or if we observe. So almost all the hemorrhages have disappeared and there is complete resolution of the macular edema. So you have to be careful in such cases just to look out for the development of NVI, because I think we delay these things. I think that is a separate discussion. So just to conclude, I think we presently need a drug which is acting long, which is much more sustainable, and it should be safe. I should have a sound sleep after giving that injection to reduce the treatment burden. So I think it has shown a very good response in patients who are not responding to aflibercept or who are dependent with aflibercept, or have got a tachyphylaxis, who were initially responding and then the duration reduced to 4 to 6 weeks. So we probably get a better response and increase the duration. So the initial results with faricimab are very encouraging for me in both AMD as well as PCV and DME. So thank you.
Much, Dr. Bhuvan. Can you elaborate on that statement that in switch patients you don't give a loading dose?
Yeah. So see, a switch patient, sir, if I have given a dose of probably ranibizumab or aflibercept and there is no response, so probably then if I shift, I will give a loading dose. But if I am giving aflibercept and I am getting a response and I am able to increase the duration to maybe 8 weeks or maybe 10 weeks, so I don't think it would be justified in that patient to give a loading dose, because that patient is already on 6 to 8 weeks, and if I'm asking him that I want to shift you to a better drug, but I'll give you monthly injections, so probably I think neither the patient will be convinced nor I will be convinced to use that drug. So my main aim is not using a loading dose in such patients. I usually keep a target that when I'm getting a drying with my initial anti-VEGF, if it is 6 weeks, then I would like to observe for at least 6 weeks and then treat at 6 weeks even if it is dry, and probably do a OCT again after 6 weeks and then try to increase the duration as a treat and extend. But if there is no response, and a switch is different, if there is no response at all after 3 injections or 2 injections, then I do a switch, then I give a loading dose.
I do agree with that, because if it would have been a treatment knife, then probably the loading doses they work. In these kind of cases, yes, we can go with PR. Nice presentation, Dr. Bhuvan. Thank you very much.
Sir, I also see the time it acts. When we give the injection, the first time we see the action of the drug, the pharisome is slightly on the higher side, means we see the action after 2 weeks, something like that. Is it
So
the
I
same?
absolutely agree with you, Vinod. I think with faricimab what we are observing is that the action is much more slower. But they have a loading dose of 4 injections. That is what they state. So in my clinical practice, sometimes I try to delay the injection by 2 weeks and give a loading dose maybe at 6 weeks. And I even try not to give 4 loading dose, but I think 3 loading doses would be sufficient. But I think the concept of 4 loading doses is that they want to go to 12 weeks directly. So if you are giving 3 loading doses, then probably you will go to 8 weeks and then 12 weeks.
So have you tried that?
What?
Giving 4 and then extending to 12?
No, I've not tried it yet. So I'm giving 3 injections and then I go to 8 weeks. But the recommendation is give 4 injections and then go to 12 weeks directly.
Yeah, I think
But I would definitely like to try it, and probably I think few of my patients have enrolled. Since we are getting it those in government panels, so probably in those patients I would like to give 4 injections and then increase the duration, because cost is a major factor.
Yeah, because this is exactly what I was just talking to Dr. Vishal, that at least with these high-end injections like aflibercept and faricimab, I think if we all start following a particular standard pattern, because with these, usually these patients would also be more compliant, so then we would have more robust data from our country as well, so which could be more collaborative, and
But sometimes I think again the problem is the cost, like giving 4 injections, although they have a patient support program, but the cost increases very
increasing.
high. So I think we have to do a personalized approach for every patient.
And initially we have been using, all patients are switch patients only, most of them. Like, we need to switch over to the naive patients more often, because this all data is of naive patients. So that is a big difference, that, we are underestimating the drug probably.
I think naive patients will respond much better.
Much better, exactly. Even I believe so. And just to add on one thing, like you just said, right, there are hemorrhages which probably, disappeared much better in that patient. I had similar feeling with even heart exudation. So even heart exudation diabetic patient had, absorbed beautifully in my couple of few patients.
Yeah, I think there are studies, and I have also observed it tends to regress the disease process of diabetes if you continue with the injection. The vascular patterns in some of them have also improved.
Yeah, I think that.
But that is even observed with aflibercept. There are reports with
kind of.
aflibercept
But
also.
the kind of absorption was a little more faster, I think, probably, yes. Thank you.